Let's hope she stays very quiet.
Right, bear with me 1 second.
Yeah, thanks, Alan. That's your recording started.
Bear a sec.
Okay.
It's just starting to snow here, believe it or not.
Oh, we've had snow. We woke up to white this morning.
Yeah.
It's starting to melt now, but it really is cold out there. Because you're in the West Country, aren't you? We're in we've got the East Beastie. It's a northeast wind, which is quite horrible.
Okay, folks, that is us showing us live on Facebook. So, as always, thanks very much for joining us for wherever you are in the world, and I hope you have a good session. I'll catch up with you near the end.
Thank you very much. Good afternoon, everybody. Good afternoon, James, again. It's wonderful to see you here.
Nice to be back.
It's nice to be back. And this is quite a successful thing we've started since COVID. It's just 2 years last week. So I'll say to everybody out there, and I'm going to give you another wee reminder. I'm very pleased that Professor James Neuberger can join us, being the sort of granddad of hepatology and PBC in the world. I'm delighted that he's here, and we'll get to your questions as best we can. Anything we can't do, we'll roll over for Dr. Bonder next week. But I would also say to you that we're not government funded, and donations have virtually almost stopped coming in. So if you're in a position to, would you please keep on donating to the foundation? Even the price of a cup of coffee, as James always said, everything is put to good use, but we can't run without your help and support. So we're doing our bit at this end, and we're trying to bring in money. So please do help us along, particularly if you enjoy this service, which I think you do. So all well today, James?
Oh, good, thanks. Yes, indeed.
Good. So, right, let's see. Marks out of 10. We'll get started. Okay. So, a wee bit background here. My GP suspects I have a muscular issue going on. Droopy eyelids, hoarse voice. Myasthenia gravis has been mentioned. Is this condition connected with PBC? I don't know if I've said that correctly, James.
Yeah, of course you have. Just to put it in context, myasthenia gravis is a potentially very serious disease where you get antibodies to which interfere with the conduction of nerves with each other. It's probably got an autoimmune basis. It can be transient, but often it's not. So yes, and you can test for it with blood tests in particular. You can also, I think, do neurological tests. But there is an association with PBC, as with other autoimmune diseases. It is very uncommon, I have to say. But the first thing to do is you've got symptoms, therefore you've got to establish a diagnosis. And with weakness, particularly affecting certain muscle groups, you have to think of myasthenia gravis, do the appropriate investigations. PBC doesn't cause myasthenia gravis or vice versa, but because they both have an autoimmune basis, there is an association, and there's a slightly greater likelihood of having myasthenia gravis if you've got PBC, but it needs proper diagnosis, it needs proper management by experts, and in those situations it can usually be managed well, but it does need to be, as I say, you need to confirm the diagnosis, and if it's not myasthenia, look for other causes, and if it is, then have appropriate treatment and support, because untreated and progressive, it can be very it can cause problems. So
okay. Well, clearly this person's GP is really on this if they've mentioned some of the rarer things like this. So I suspect that this person's in good hands. So anything further, if this person's in the room just now or on Facebook, if we can help further, then please come back to us. But I'm impressed that your GP's mentioning rarer conditions. So the next one, James, I was diagnosed with PBC in 2017. My doctor said I should have a DEXA scan every 2 years. I was diagnosed with osteoporosis late 2021. Bone density has decreased each time. Should scans be increased or not? I'd get them as often as your doctor recommends if you have PBC to catch early, should it come your way. So how often should they have scans? And one has to assume from this question too that this person has also been treated. There's a number of medications, is there not, for osteoporosis, James?
Right. So just to recap on osteoporosis is thinning of the bones, and that there are many causes for that. It can be congenital, it can be acquired, and many people, as they get, and the risk factors for osteoporosis, old age, as you get older, is one of the consequences. Usually your bones get thinner. It's more frequently in women and is affected by hormones as a consequence. It's more common in people, particularly with cholestatic liver disease, such as PBC. It's more common in smokers. It's more common with alcohol and certain medications, particularly steroids. The consequences of osteoporosis are variable, ranging from no symptoms and no problems to major collapses of the bone and bone fractures. So, for example, osteoporosis is one of the commoner causes of fractures of the hip after a fall, the trivial fall. You can compress your vertebrae. That gives you shrinking of the thorax, often a hunch, what we call a kyphosis, that's a bowing of the back. And for several weeks, it can be extremely painful. You can get other bones that are affected, but it's primarily the hip and the vertebrae that are the main focuses of attention. Now, the way we assess osteoporosis primarily is by DEXA scanning, which is a form of X-ray. It's a mild dose of X-rays where they measure the amount of whiteness, if you will, or how X-rays get through. And there are two measurements that I always get muddled that are important. There's a T-score and a Z-score. It's quite a complicated score to understand, bless you, but one component measures how far of an outlier you are within the general population. So the lower the score, the more of an outlier you are with the general population. I think that's a T-score. The Z-score is age adjusted. So as you get older, your bone density falls, as I mentioned, and therefore one will tell you your absolute bone density or a guide to the absolute bone density. The other will tell you your bone density relative to people of your age. Now, although bone we think of as fairly solid, like a bit of scaffolding, it is quite an active organ, but changes in calcification or decalcification occur relatively slowly. Now, this means that it's probably not worth repeating the scans too frequently, because any change in bone density will not be apparent if you repeat it too quickly. There's always an error in these measurements. There's variability because the person changes, their skin fold thickness changes, the fat changes, the water changes, the X-ray machine may change, and it's rather like measuring somebody's height. If you measure it every couple of days, you won't notice them growing. If you measure them every 6 months, assuming they're children, you'll notice they're growing. So if you measure bone density too frequently, you lose, you get information you may miss important trends. And you don't know if a slight change is due to natural variation or due to a change in bone density. So my teaching, which is slightly out of date now, is there's no point in doing bone densities more frequently than 3 yearly, and sometimes even 5 yearly, because any slight changes. Now, what do you do if you've got osteoporosis? Well, what are the risk factors? As I said, some of them you could modify. There's nothing you can do about age, I suppose, apart from shoot yourself. And then you all that. I wouldn't advise that for most people.
Nope.
I can think of a few, Donald Trump for one, who I would recommend that.
I won't name anybody in Scotland.
Yes. When she just. And obviously stopping smoking, reducing alcohol, look at the medications that you're taking to see if they are contributing to osteoporosis and whether or not they can be modified. So sometimes if you're taking steroids, there really is no safe alternative. In other cases, there are strategies you can adopt to minimize the amount of steroid you're taking. So potentially if you're on, say, 20 prednisolone, in some cases, it may be that you can go on to mycophenolate or azathioprine and allow control of your disease with a reduced dose of steroids. But again, I would stress that it's something to discuss with your doctors and absolutely not to do off your own back. Exercise is another very important way of reducing osteoporosis and the risks. And for it to be effective, it's got to be weight bearing. So swimming is not weight bearing. It's very good cardiovascular exercise, but it doesn't do anything for your bones. Whereas weightlifting, active walking, all those things which are weight bearing will help reduce osteoporosis or reduce the rate of osteoporosis. So also important to have a good diet, particularly plenty of calcium. And for those outside Scotland where you can access sunlight, sunlight will also help with vitamin D levels. So there are so the normal practice is to look at, particularly in PBC, the recommendation is to have bone density assessed. If it's normal, then general advice: stop smoking, avoid appropriate medication, plenty of calcium, vitamin D, plenty of exercise is all that is needed, and repeat every 5 years. If you've got reduction in bone density, then you really need to get some expert advice. As Collette indicated, there are a number of treatments that are available. They don't usually reverse osteoporosis. They usually prevent progression. And that's important. Some of them will do, but there are a number of different treatment regimens. They will depend on your age, whether you're pregnant, what your kidney function is like, for example. And bisphosphonate, so calcium and vitamin D is thought to be helpful in some. Bisphosphonates is the commonly used medication, but there are several others. So with severe osteoporosis, again, you want expert advice. But to go back to the question, if you are starting to get bone thinning, you need to take action now. Take plenty of exercise, get out in sunlight, make sure your calcium and vitamin D intake is adequate. It doesn't do any harm to take multivitamins. It's probably a good thing, provided you don't exceed the stated dose. Give up another reason to give up smoking. But if your bone are thinning, then get advice. And as always, if the treatment is effective, that's great. If you get bone thinning despite treatment, then you need to talk to your doctor about ramping up the treatment to prevent bone thinning. Because once the bones are thin, it's much more difficult to re-establish the normal bone density.
Can I just go back to the diet thing? I was one of these Many people who thought it was what you ate as a child and a teenager that really mattered. And the last time I had a DEXA scan, it's all changed in the years that I've been having them. I had a very extensive questionnaire to fill in, particularly around diet. Now, my DEXA scan was fine. I was very lucky. But they were quite clear that I wasn't taking in enough calcium because I'm not into milk and cream and things. And I was quite surprised that there's calcium in bread, there's calcium and lots of other things that I do enjoy. So if you're not sure, look on the web, look where you can find calcium in food. You'd be quite surprised if you're like being a wee bit, you don't fancy dairy very much, without taking anything that's excessively sweet and sugary, etc., and fatty. So do have a look around, but diet is really important. I had that impressed upon me, which I thought I would just impress upon you. I'd pass it down the line. All good tips are worth having. Okay, are we happy with that one, James? Mm-hmm. Okay, so we go on from this. A new question. I suffer with really bad pain in my teeth, mostly my gums, with PBC. I've tried gels and salt water and whiskey on them, but sometimes has mean tears with agony. Sometimes I just have to rub hard and hold pressure on to erase it. Is there anything you can suggest or tell me? I'm really sorry to hear this. This must be awful for you. There's not a lot of information here, and I don't know. I'm assuming that you will have seen an orthodontist, a dentist, a specialist, perhaps a rheumatologist to talk about Sjogren's syndrome. Is it a bit vague, James? Can you add anything to this?
No, I mean, I saw this question and I had a quick look, and essentially, gum pain is not a feature of PBC, so don't attribute it to that. Certainly, people with PBC can have Sicker syndrome or Sjogren's syndrome, where you get reduced secretions of saliva into the mouth, and that can affect dental hygiene. Some medications will also affect the gums, but I think you need to see a dentist, an orthodontist, dental surgeon, and get proper advice, but don't attribute it to the PBC. Rubbing whiskey on it, I think, is a waste of good whiskey. I'd drink it and enjoy it. But I would get it. Don't attribute it to the PBC. Don't let other people dismiss it by attributing it to the PBC. One thing that so analgesia, obviously, pain relief may help. Topical pain relief, whether any of the non-steroidal anti-inflammatories are suitable for the mouth, I'm not sure. Talk to your pharmacist, and they might be able to give you some advice about topical relief, but that is only a stopgap. What you really want to do is to find out why you've got the pain, and then have specific treatment. Painkillers are temporary band-aids, if you will. But get your dentist. If your dentist can't sort it, ask to be referred to the dental hospital or the ENT specialist.
Okay. And, if I can help in any way, please come back to me, the person who asked that question. I'd be delighted to chat further on the phone.
I mean, just say one other thing, that sometimes pain in the gum line is not actually due to gum or teeth dental problems. It can be due to referred pain, and in particular things like temporomandibular joint problems can give rise to pain in the teeth, sometimes, and the problems in the jaw joint here. Sometimes sinus problems can give you referred pain, but don't put up with it. Take pain relief till you get a proper opinion, and you need a diagnosis. Which is, and don't let them fob it off with PBC.
No, absolutely, 100%. Thank you, James. Background: I've been diagnosed 2 years, holding steady. You could hold steady for another 32 years. I'm starting to develop shortness of breath, and I get tired very easily. Exercise isn't helping. I also keep getting bronchitis, but never COVID. Is this part of having PBC? Before I hand this over to James, I'm going to say to you, don't stop the exercise unless somebody specifically tells you to stop it. because you actually don't know how much the exercise is helping. Although you don't seem to be getting any worse, it won't be doing you any harm for sure. So an interesting one, James.
Yeah, I mean, there are many causes of shortness of breath in people with PBC. Obviously, is it related to the PBC specifically? There are some conditions which are more common in PBC, affecting the lungs, such as fibrosing alveolitis. There are some diseases of the lung which are more common in people with liver disease of any cause. These are what's called hepatopulmonary syndrome and portopulmonary hypertension. In hepatopulmonary syndrome, you get shunting. So blood, as you know, blood leaves the sort of deoxygenated blood that's come around the body, enters the right side of the heart, goes through from the right side into the lungs, where it's oxygenated, and then it goes back into the left side of the heart and then pumped around the body. In hepatopulmonary syndrome, you get bypasses, if you like, in the lungs. So the blood goes through the lungs, but bypasses it. It doesn't go through the little alveoli where the gas exchange takes place. And therefore, unoxygenated blood enters the left side, goes around the body. So your body gets starved of or has reduced levels of oxygen. And that can make you breathless. And that is part of any form of particularly cirrhosis. And it can be difficult to treat. And sometimes even we transplant people for that indication. Hepatopulmonary syndrome is where you get high pressures in the right side of the heart. Again, a feature of liver disease in general. And then, of course, there are all the other causes of shortness of breath. COVID, and I know from the thing that your tests have been negative, that makes COVID very unlikely, although one of the features of long COVID is shortness of breath. So you may have got rid of the virus, but the shortness of breath persists, and that can do for many months or years. There are many other causes, emphysema, chronic obstructive pulmonary disease, impact of smoking, etc., etc. So many causes. And if you're getting short of breath, then go and see your doctor who needs to examine you. They'll probably run some simple blood and other tests, maybe a chest x-ray, maybe your blood, your flows to see if you've got a form of asthma, see if you've got obstructive airways disease. It's sometimes helpful to measure the oxygen saturation, both at rest and at exercise. As I say, a chest x-ray. If those tests don't give an answer, then further investigations are required. But there are many causes. I've only given a few, but increasing shortness of breath does need proper evaluation. So go to your GP. Yes, it could be related to the PBC, but don't assume that. Get a diagnosis and take it from there. And if you're smoking or people around you are smoking, stop smoking, stop them smoking near you, because whether or not that's the cause of your shortness of breath is going to make it worse, whatever the cause.
And controversially, without any judgment whatsoever, and we've seen this over the last couple of years in other areas of liver disease, but some people during COVID and lockdown have put on a wee bit extra weight as well. And that can obviously make a difference to your levels of fitness and how fit you're feeling and cause breathlessness too. So, don't discount anything, but James is right. You certainly need to some more tests to try and to get to the bottom of it.
But what is quite helpful for the clinicians when you go to your doctor is to give some quantification, some measurement of your shortness of breath. So, for example, is it there at rest or is it there on exercise?
Mhm.
If so, if you walk fast, how far can you go?
Yeah.
Can you manage a flight of stairs or 3 flights of stairs before you become breathless? Is the breathlessness worse when you're standing up or lying down? Do you get breathless at night? Do you bring up any cough? Do you have a cough? Do you wheeze? Do you bring up any phlegm? And if so, what color is it and how much? I'm not asking you to measure it, but is it a small amount, a teaspoonful, an egg cupful, or a beer glass full? That will very much help focus the avenue to take. So if you can get some guidance for your doctor to say, how long have you had it? Is it getting worse? How far can you walk? How does it affect your daily exercise? Lying down, standing up, walking upstairs, cough, spit, wheeze, all those things have in your mind so that it'll save time.
Yeah, no, that's very helpful. I am squeamish, James. I am.
We'll talk about the different colours of sputum then.
Now, my next question, their first question was about myasthenia gravis, right? So I've now got a question saying, is my asthenia gravis associated with PBC? Is it the same thing or is it something different?
Yeah, I think you've got to separate asthenia, which is just a sort of posh term for weakness, and covers a multitude of symptoms and diagnoses.
Asthenia gravis then?
But myasthenia gravis is
not myasthenia.
No, but to see, so I suspect they put a space where it shouldn't be,
right?
And it's myasthenia gravis, which we've discussed. Asthenia is
so
sort of like brain. Yeah,
we've covered it. Okay, great. So next, can you provide any information about taking the following supplements when you have PBC? I take Urso each day. Good. Solgar magnesium tablets. They're meant to improve energy, etc. Can you comment on Solgar magnesium tablets?
I don't want to comment on particular supplements.
Right. Okay. Right. Fine.
But in general, if you're having a sensible, well-balanced diet, and a well-balanced diet means not having one large cake in each hand, on the whole, if you don't have any bowel problems, then your diet is probably going to be adequate. You're going to absorb your food, and if you're having a good intake, you usually don't need supplements. There are very good supplements, and to take, for example, Multivite or similar is sensible, and these medications are very carefully regulated. They're controlled so that if you take the prescribed amount, the recommended amount, you won't run into harm. But just as deficiencies of minerals, including magnesium and calcium, for example, can cause harm, so can too much calcium and magnesium cause harm. The fact that low mag is involved in energy, for example, doesn't mean that taking any more energy, any more magnesium improves your energy. Think of it rather, perhaps not a good example, but if you're filling up your car, if you can afford to these days, provided you've got enough fuel in your tank, then the engine's going to work. If you overfill your tank, you're not going to get anything better. You're just going to spill and ruin your tires and the tarmac. So to take these supplements, as long as you take them in the prescribed way, won't do any harm. If you find they do help, then by all means carry on. But don't assume because they're natural, they're safe, and don't assume that because the deficiency causes problems, giving you a lot more will give you energy. If your energy lack is due to not enough magnesium, then sure, taking more magnesium will improve it. But if your lack of energy is due to the PBC, then however much magnesium you take, it's not going to make a difference. So if you do take supplements, take it within the prescribed limits. Remember, Holland, those companies that promote all these vitamins and supplements are making a good profit. And you may be taking the medication and just peeing it out or losing it in other ways. But as I say, don't assume that more is necessarily better. More can be worse. It can be harmful. Too much calcium can stop the heart, for example, and give you kidney stones and abdominal pain, for example. So if you do take medication, try it out, see if it does improve anything. If it does, then no harm in carrying on, but don't exceed the stated dose. And also, if you're taking multiple vitamins, make sure you're not taking, for example, vitamin D in your multivite and vitamin D in your calcium and vitamin D tablets and vitamin D in some other preparation, or you will get vitamin D toxicity, and that can be fatal. Only once, but it is.
No, I've actually spoken to 1 or 2 members who have overdosed on vitamin D. Now, I'm just going to say to everybody, I've got questions coming in through Facebook, which Linda is transporting to me. And I've come on to the second page of questions here. And one particular person has asked 6 questions. Okay. And somebody else, we have to give everybody a shot here. It's a wee bit unfair. And it's also got quite a lot of it's personalised. So I'm going to ask James, in the interest of fairness to everybody, to keep these, if we can keep them quite short. And if not all these questions can actually be answered, as you are not James's patient, but please be a bit mindful, is what I'm saying. 6 questions are an awful lot to ask, because other people then have to wait and maybe until next week or the week after. So please bear that in mind. So I'm going to, if we deal this as quickly as we can, I'll tell you what, I'm going to come to a quick, an easier question first. Can a sudden drop in the serum B12 be related to liver disease, injury, infection, or PBC onset? Intrinsic factor, antibody negative. Now, of course, vitamin B12 is what they describe as pernicious anemia, and we know that people will have top-ups of vitamin B12 every 3 months by injection form, or if you're a dog that belongs to me, she gets tablets for it, because dogs get it as well. So she's basically, this person asking, is it related to liver disease, injury, infection, or PBC onset?
Right. Firstly, if you get usually people with liver damage of any, even the mild sort, often have slightly higher levels of B12 because vitamin B12 is stored in the liver. And when you get liver cell damage, as occurs in PBC to a mild extent, that usually gives you a high level of B12. I think the first thing that I would do in somebody who's had a consistently normal level of B12 in their blood is, and there's a sudden drop, is to repeat it. Is this just a laboratory error, or is this a real finding? B12 deficiency, there are many causes. It can be due to dietary inadequacy. It can be due to lack of absorption. And pernicious anemia is one form of B12 deficiency where you get, so for B12 to be absorbed, your stomach secretes a compound called intrinsic factor. And intrinsic factor binds to B12 in the diet or in the bowel, and you absorb it that way. And if you don't have intrinsic factor, you won't absorb the B12.
Well, that's what they say. It's negative. The antibody's negative.
Yeah. So again, is that a valid test? You see it in other conditions. Is there a problem with malabsorption? But I would first of all, again, if you have true B12 deficiency, then your red cells become slightly bigger than normal, and that's called macrocytosis. That's one of the causes of enlarged red cells. But so if your red cells are normal size, you get one unexpected drop in B12, I would just repeat it and see if it's a real finding or just a technical error. Maybe the sample was damaged in transit. It may be that the machine was having a bad day, a bubble got into it or something. So I'd first of all check it, and then I'd want to know why the B12 was low. Is it, so check the diet. Are you eating the right foods, the right meats, for example? And you can get B12, you can get it orally, you can get it by injection. But I think, again, is it a real finding is the first question. If it is, why? And thirdly, replace the B12, depending on the reason for it being low, whether by injection or by tablets.
Okay. Yeah. Okay. Now this next one, is not a member. This person's a non-member, but it's actually not clear if they have PBC or not. So I'm going to read this out, and I'm going to say to this person, and she's a 33-year-old woman, that we really need to know if you've been diagnosed with PBC or not. You've been a bit vague, but I'm going to read this out and we'll do what we can, because you do seem to be having some awful, awful problems. 33 years old, I have restless leg pains that have had me in tears. Hardly slept for over a year and so tired I can't take my children to school, which is really sad to read this. I feel sick when I eat, suffering bad itching and swelling in the ankles and hands.
I'm sorry, so yes.
Sorry.
No, carry on. No, please continue.
Will I start from the beginning?
Yeah, no, I heard that she got restless legs and feels.
Yeah,
I've got the question in front.
Suffers bad itching and swelling in the ankles and hands. Recently had a major attack with worse pain. Hospitals thought it was gallstones. So there's a lot more to the story than we know. Ultrasound showed bigger bile duct dilated, had an MRI flam, inflammatory markers was up. My mum has autoimmune disease, I don't know what, and she's had severe dysmenorrhea for years. I don't understand what's going on, how far into PBC I am. So I suppose she is saying she has a diagnosis, but we don't know what medication that you're on. She's suffering some awful things here, but it's how best to help her, James. Well, I would ask her to come to join us and go on the website and just join in as a member. It's free of charge, and have a look at our information. But what can you add to this, James?
Okay, several things. Firstly, please do join the members as a member, and if you have PBC, that's to say, when Collette says it's free, whenever you hear the word free, substitute in your mind somebody else is paying for it. So do remember that all these things do take money.
Tiny money.
If you want to give a contribution, we'd be very welcome to take it. And if you can, gift aid it so we can get a bit more from the Treasury on top of that. Restless legs can be a very severe problem. It sounds trivial, but it's not. It's really difficult for the person. And there are various treatments that are offered with varying degrees of success. We don't really understand the cause of restless legs. It's not psychological, but there are various treatments to try. There are various licensed treatments. So go to your GP and ask for help and treatment for them. But it sounds a trivial condition.
It's not.
And it's not, and it needs proper treatment. And if you're, not sleeping because you can't get to sleep because of restless legs and the impact, etc., etc. So yes, it's taken seriously. Yes, there are treatments available for it, and find out what works for you. Now, the next question is, what's going on? I notice your mother's got autoimmune disease, you've had dysmenorrhea, and both those suggest it could be PBC, but obviously you're in the right, it sounds like you're getting the right care, and what your liver tests are like, what your or antibodies are, your antimitochondrial antibody levels are, and so on, will help make or disprove the diagnosis. Enlarged bile ducts, again, it depends how enlarged they are. There is a variation in normal. Sometimes, for example, after gallstone surgery, you get slightly enlarged bile ducts, but there are many causes for enlarged bile duct, and an MRI is definitely the first test to do to look for various causes. It could be gallstones, gravel, and many other conditions. But it seems to me that there are a number of issues that need resolving, and work with your doctors to get a diagnosis. Once you've got a clear diagnosis, then the management is usually much more straightforward. But if you've got PBC, that may not necessarily explain the enlarged bile ducts, but you're having the MRI, which is a very sensible way forward. The inflammatory markers are often up in PBC, but they can be due to other factors as well. The dysmenorrhea could be related to the PBC or to the liver problems, but again, there are many other factors. And one needs really the complete picture, and you need to work with your GP and specialists to identify what's going on, what can be attributed to the liver, what can't be, and take it from there.
Yeah. And don't hesitate. Please do come back to us. I would like to hear from you anyway, just to hear how you're going, and let's see if we can get you some help. Okay, I'm coming up to this one with the six questions, and I've got they're stacking up on my computer here as well. So we're going to do this very quickly, if that's okay. Background in a conversation with my hepatology nurse, which is great. You've got a hepatology nurse. Pleased about that. The results of my MRI scan. My liver's now cirrhotic. She said a biopsy won't assess the level or spread of damage, okay? Esophageal intervention is to be arranged. They mentioned my portal vein, ? Well, of course, we wouldn't know because we can't see what they saw. Cancer risk is now increased. I'm due to have an ultrasound in another 6 months. That's fantastic news. It's precautionary for a lot of people with PBC, with fibrosis and cirrhosis, and it's a great service. So that's good that they're keeping an eye on you. Many boxes ticked there. So a load of questions. Is it possible to assess the level of damage to the liver is the first one.
Right. We'll go through them in order. Now, how you assess how the liver is damaged or how well it's working is not a simple question. It's like saying, how well does my car work? Because you can have the electrics that are knackered, you can have the tires that are not working, or you can have the windscreen wipers that aren't working, or the wash bottles empty. The liver has so many different functions, and different aspects can work well and badly. So the level of damage, one often thinks about the degree of fibrosis, the degree of scarring. Now, you can have people with established cirrhosis from many causes, and the liver is actually functioning very well. You can have people with milder damage and more severe symptoms and consequences. So it depends what you mean by level of damage, but most people talk about fibrosis and scarring. Now, the other point to mention about this is that within the liver weighs about 2.5 kilograms if it's normal, and what goes on in one part of the liver is not always mirrored closely by what goes on in another part. To assess how well the liver's working, there are essentially two robust measures that we use. One is the FibroScan, which measures how sound waves bounce off, and that gives you an E-score or an elasticity score or an attenuation score. It's called different things. And basically, the higher the number, the more likely you are to have more fibrosis. Mm-hmm. And if it's over, the higher the number, the greater the chance of cirrhosis. That is probably the easiest, most commonly used one in the UK. There are blood tests that you can measure. There's a so-called ELF score or ELF score, which is another way of assessing the fibrosis. So those are the two that we use. Liver biopsy can be used to assess the degree of fibrosis. It's rarely used now for that purpose because FibroScan is non-invasive, cheaper, and far less painful and hazardous. So the consequences, if you have cirrhosis of any cause, there are two important ones to consider because you want to screen and survey people to prevent the problems. The first one you've identified in number 5, which is cancer of the liver. Now, in the UK, it's not the same in Asian countries. Cancer of the liver is still relatively uncommon, but the major risk factors are predominantly cirrhosis from any cause, being male, and having one of the known hepatitis viruses, such as hepatitis B or hepatitis C. Smoking will also raise the risk of liver cancer, as will alcohol. Now, liver cancer develops slowly, and basically there are two ways in which we can monitor people for that. And anybody with advanced cirrhosis advanced fibrosis or cirrhosis should be offered a surveillance program. And we do that primarily using two methods of assessment. The first is an ultrasound every 6 months. That's usually adequate to image the liver. In some people it's difficult, and so CT or MRI is used, but 6 monthly imaging of the liver. The other test that one will do is a blood test called the alpha-fetoprotein. Now, this is a protein that's found in normal people at low levels. It goes up in several conditions, including it's often elevated in babies. It can go up in inflammation of the liver, so it's increased in hepatitis. It can go up in some other cancers, teratoma, breast, bronchus, and so on. But in the liver, if you measure the alpha-fetoprotein over 6 monthly and you watch the trend, a rising level raises the possibility of liver cell cancer. It's important to monitor because if you detect the cancer early, you can often cure it. There are a number of approaches you can use to cure liver cancer. Chemotherapy is increasingly used. It's still of limited efficacy. You can also inject the cancer with alcohol. You can put X-rays at it. You can inject it with other agents. You can embolize it. So you can remove it occasionally. So there are a number of options that if you get cancer early, you can cure the patient. If it's too big, then sometimes transplantation. But the number of options for liver cancer now are increasing. But so to have the imaging and the blood test every 6 months, if you have cirrhosis, is important.
Yeah, I think we should leave that one there because this person does have access to a hepatology nurse. And I think you have covered everything, to be fair.
The other thing that I haven't covered is the esophagus. Because
can we do that very quickly?
Yeah, that's important because
it is, but you don't know where this person is.
No, but
they're asking about themselves.
I accept that. But for those who are listening, if you have cirrhosis, you're at risk of getting portal hypertension, which means the pressure in the blood vessels of the portal vein increase, and that leads to the development of varicose veins anywhere in the GI tract from the mouth to the anus, but it's of particular importance in the gullet, in the esophagus, and the stomach, where they're known as esophageal or gastric varices. Now, these are asymptomatic if they're present, and they remain asymptomatic until they bleed. And when they bleed, it can be difficult to control and can be very serious and fatal. So if you have cirrhosis, the policy and it sounds your unit is on top of that, is you do an endoscopy to look for varices. And at the moment, there's no other robust way of looking for varices. If you have varices present, so if you don't have varices present, but you have cirrhosis, then you repeat the endoscopy in 3 years. If you have small varices, you may just observe. But if they're larger varices or have other concerning factors, then you would either be offered medical therapy or injections or both. So these greatly reduce the risk of bleeding. They greatly reduce the consequences of bleeding. So again, with cirrhosis, 2 surveillance programs, varices and cancer, both are important. And you have to collaborate with the centre to make sure you have your 6 monthly imaging and blood test for the cancer, your regular endoscopies or treatment for the varices if they're there. I hope that helps.
I'm sure it does. I mean, there's a lot of questions there, and I'm going to fire on, James, because they really are pouring
Right.
in. So this person says, I haven't seen a consultant since 2019. Previous to COVID, I saw a consultant every 6 months and I had bloods checked. Can you see face-to-face appointments returning at any point? I don't know where you are in the UK. They are returning for many, many people. Make sure, firstly, you get your bloods checked every 6 months. Your GP can do it and send the bloods along to your hospital. But drop your consultant, your nurse, whoever's looking after you, an email. And if this is what you would like, then ask for it. Ask them directly, because it seems that every hospital around the country are doing different things at the moment. Is that reasonable, James?
Yes. The situation, I mean, hospitals have been under enormous pressure.
Sure.
Doctors have been deployed for emergencies with COVID. Face-to-face have been reduced, partly because of the logistics. You don't want all your patients, many of whom are vulnerable, to be sitting around close to each other. You don't want them to be exposed to doctors and nurses because they may be carrying the virus and so on. And now, as we're starting to come to terms with the pandemic and go back towards normal, hospitals are prioritizing their patients. Whether you need to, how quickly you should be seen depends very much on the state of your PBC. If you've had it for a time, you've got very early disease, well controlled on URSO, no major symptoms, then there's no great blood urgency. If, on the other hand, you're symptomatic, your liver tests are becoming abnormal, you're not on a proper dose or not responding to URSO, that's a very different scenario. So get your blood test done, talk to your GP, talk to your hospital, and they will try and fit you in, but it's a matter of balancing resources and dealing with the most pressing people first. But get in touch and see where you go. Some centres aren't that good at responding, so keep on. If you don't get a response to an email or letter, keep trying. And if after 3 attempts you get nothing, write to the chief exec.
And complain. Okay, quick yes, no. Is it okay to have Botox when you have got PBC?
It depends where and who buy and how. And if your liver disease is not too advanced, then yes, yes, there's no medical reason, as far as I'm aware, not to.
Okay. FibroScan results stated mild fibrosis, but told me that my bloods do not concur and all as well. Bit confused. Should I be concerned? I actually don't understand. My bloods do not concur and all as well. I think this person needs to come back here.
I think the blood tests, again, it depends the degree of fibrosis. Was the FibroScan done correctly? Has it been repeated? Does it show any significant change? The blood tests reflect the FibroScan reflects fibrosis. The blood tests will reflect different things. It may reflect information of the hepatocytes, of damage to the bile ducts. So there's no, as I said earlier, there's no one simple measure of how good or how bad the liver is. different aspects have different ways of being assessed. So if your fibre scan is consistently showing mild fibrosis and your liver tests are elevated, that is not necessarily inconsistent. If your fibre scan and your ELF test disagree, then again, that is inconsistent. But they usually measure different things. So I wouldn't be too concerned that they show you different things.
Okay. Right, so we've got 2 questions left. Here in the US, talk of another booster for COVID. I've had 2 Pfizer vaccines plus the booster. So I've read you might be off to get a Moderna booster. What's your opinion? I do know that, because I had 2 Pfizers and a Moderna, but I do know some people in this country have been actually given a forced booster, James. You know, but a couple of girls have got lupus and they've been given a forced booster. What the question is here, what's your opinion? I think part of this is about the different companies, which we all seem to be getting a jumble of. And secondly, you know, another booster, are you okay with that? But you're very pro, like me.
I can't understand the stupidity, and I'm use that word advisedly, of people who don't want to take a vaccine. It's selfish. Of course, they're entitled to make that decision, and one should respect it, although they are putting other people at risk, both for passing on COVID and taking up unnecessarily intensive care unit beds. So until recently, people were not getting cancer treatment, were not getting heart treatment, because ITU beds were blocked by people who had COVID and could have avoided taking up the ITU bed. Yes, you're entitled to do that, but it's like saying I'm going to jump out of an aeroplane and I'm not going to take a parachute. But people have their views. If you're offered a booster vaccine, I would jump at it. The arguments as to whether it's good to change preparations or stick, I think the experts are still out on that. Certainly the 4th dose is being rolled out. Now in England, it's the over 75s and the vulnerable. I'm sure that will be spread wider and wider. But yes, provided there's no contraindication, jump at the opportunity, be really grateful that you're one of the lucky ones.
Absolutely.
And think of the millions around the world who don't have access to it and count yourself lucky.
And you know, and they said about the 2 vaccines and the Moderna, and I had 2 Pfizers and the Moderna, as I said. And last week, both my husband and I had COVID. And he's a very, very healthy man, and he doesn't have PBC, and his symptoms were far worse than mine. So it's all a hit and a miss for reasons we don't know, we don't understand. But if you're offered it, just take it. I don't think it really particularly matters, James, which one it is. I think as long as you're offered it and you take it, I think. So our last question is a belter of a question. Since my URSO was increased from 1,000 milligrams to 1,250 in the middle of January, I have gained at least 8 kilograms. I'm horrified, to be honest. Some could be down to diet and less activity, but not all of it, surely. Is it possible URSO is a culprit?
Yes, it's possible. I mean, people do put on weight with URSO, that's true. The mechanism of it is not entirely clear. But as with all medications, you know, risks and benefits have to be weighed, and there's no doubt URSO is a highly effective way of reducing your rate of progression of PBC. The weight loss is relatively straightforward. You either have to eat less or take more exercise or both, or amputate a leg, I suppose, is another way of reducing your BMI. A bit drastic. Changing your diet sounds easy, but in practice is a lot harder than it sounds, and many people would struggle to lose weight for all sorts of reasons. It's not as simple as one would believe. People vary, and my tips for people trying to lose weight is, firstly, don't go on a diet. There's very good evidence, yes, if you go on a lot of these diets, keto diets, whatever, 5-2 diets, you will lose weight, undoubtedly, if you stick to them. But most people don't stick to them forever. They stop the diet and they rebound, and often the evidence shows they gain more weight than they've lost. So don't go on a diet. Look at what you eat. The second thing I would say is don't cut out foods entirely that you enjoy. If you enjoy chocolates and ice cream, etc., if you go on a chocolate-free diet and you really like chocolate, you're not going to stick to it. The secret, I think, is eat what you like, but eat less of it. And the second thing I would say is don't eat between meals. A lot of people snack. There's that myth that if you eat standing up, it doesn't count. That
I haven't heard that one before.
that the diet Coke cancels out the Mars bar. That doesn't work either. Have what you enjoy. Have your meal, 3 or 4 meals a day, but just have less. Don't have second helpings. Don't eat between meals. And if there are ways you can reduce your caloric intake, for example, don't have full sugar Coca-Cola or Iron Brew if you're up north. Go for the low-calorie ones. If you have sugar in your tea, etc., go for your low-fat milk. But so you can get rid of the low-hanging fruits that way. But just eat less and exercise more. And for most people, that will work. But there's some people to whom it's a real medical problem, and it can be very, very difficult to lose weight, and we shouldn't be judgmental. People don't choose to be like that. They're not happy like that. There are enormous medical, psychological issues. And if it's not working, then talk to a dietitian. It's probably worth writing down what you eat just for a few days. And most people are quite surprised. Snacking, people often don't count. They go and have a biscuit with a coffee in the morning and they don't consider that, etc. But it is difficult and there's no simple solution. If there were, and I patented it, I'd be far too rich to be.
Yeah, I'm going to add on to this because as somebody who struggled with weight ever since I started taking or so in my late 30s. And I've tried various things, and James is absolutely quite right. And what he's saying is that if you go on these sort of faddy diets and start missing things out, you get into a cycle and then you feel a failure psychologically, emotionally. It's quite damaging. You try something else and the cycle repeats itself. What I would say to you, I think people with PBC, I think James is right about the snacks. I was never brought up in snacks. I had my mother was, evacuated during the war and they had rationing. So we had 3 meals a day and that was the end of it. I think the snack thing is huge. I think sugar is huge. Unlike James, I'm not a big sugar fan. I think it's quite a toxic thing to have. But I will say this, I think, and I've lost 3.5 stone and I've done it very slowly and very carefully. And there's something called Pinch of Nom. And Pinch of Nom are amazing books you can buy on Amazon. And they're cookbooks. And simple, nutritious, fantastic recipes. There's curries, there's soups, there's sweets, there's things for sweet tooth. But what you do with these recipes is you batch cook. And when you've got PBC and when you're tired and, juggling job, house, kids, lots of things to do, often you neglect yourself. You think, well, I'll just go and have. And what you just go and have is something maybe not that very healthy, and you'll have more of what you would normally have because you're tired and you're trying to buy into a bit of energy. So have a look online at these books if you like. But I would definitely recommend batch cooking because the days I'm tired, the days I'm busy, the days I'm optimizing it, I just go and grab a box out of the fridge. Everything has 400 calories in it, lots of good food, lots of nice things. for every taste. Give it a try, have a read about it. That's my experience. But I do think the snacking is a biggie. And I think that just grabbing something on the run is part of a problem, particularly when you've got PBC and you're juggling all the balls in the air at the one time. And I would happily speak with anybody about diet issues because I do understand. And James is absolutely right. We don't choose to be like that. We don't choose to be fat or overweight. And it does have an impact on what we do and what we can do physically. And going to exercise, I mean, it's a number out that's in there. They say they click 10,000 steps a day. Why not try and do 10,000 steps a day? You don't have to go outside to do it. You know, you can go and phone your mum or phone one of the kids and walk around the house. You can build up 10,000 steps a day quite easily. So that's my wee 10 pence worth. I hope it helps. James, we've overrun a wee bit. Many apologies. Now, we've had lots and lots of people in today. I'm going to say to you again, we've got virtually no donations coming in. Nothing's coming in. I know people are strapped, but we're becoming strapped too. If you enjoy the service, if you need the service, if you want us to continue the service, please, even the price of a cup of coffee, if you go into Costa or Cafe Nero or whatever, give it to us. Go online and just donate a few quid. And if you've got much more than a few quid, then help us with that too. But these services, as James says, they're free to you. But I have to go with my team and find money to pay for all these things. So if you can, I'd be really grateful. So I'm on holiday next week, everybody. But I will be doing, I think we've got Alan Bonder from the States. He's doing question time. James, thank you so much for your time and your expertise. And here's Alan. Did you learn something today? You've learned about snacking, about a pinch of nom, James. I bet you've never heard of pinch of nom.
I've actually learned that if you amputate your left leg, you lose weight.
It works for your right leg too.
Well, Alan, thank you. Thank you, Linda, in the background. Chris is off getting his hearing aid sorted. But everybody working in the background, there's a team of people here, everybody. You know, everything stops in the office, the phones get put off, and we all concentrate on this for an hour and a half, however long we run. James, thank you so much. We'll catch up here at some point. Well, we'll know with the 5th of May you're coming back. On the
5th of May, yeah. That's affirmative.
I hope all's well with you, Alan, and with your missus and everything, and we'll speak soon. So thanks for joining us, everybody. I hope
everybody.
If there's more we can answer or you want to further anything, just come right back to us and we'll get it sorted. Bye, everybody.
Thanks so much.
Bye. Bye. Oh, you're welcome, Caroline. Bye-bye.